you'll see it as we go through in red. I'm going to stick to those main concepts. Those are the things that are critical and important. I don't want you to get lost in the details because there is a lot of information here. Good morning. All right, so I gave you just a quick background, 1 or 2 slides on opiates, because opiates is what everybody thinks of when we talk about pain. What I hope you walk away with today is that you have a better appreciation of acetaminophen and ibuprofen, and that when they do tell you or prescribe higher doses of those drugs, that you don't laugh at them and say, oh, this isn't going to help me. That if you use it appropriately, that they are safer and great drugs for, I would say, probably 90% of the type of procedures and pain that you experience. But opiates have been around for a very, very long time, and it wasn't until the late 90s that it really became an epidemic. Does anyone know why or what the underlying cause, driving factor of the opioid epidemic was?
About addiction.
That came in the early 2000s.
Like the over prescription of them, like they were giving them out.
Do you know why? Do you know why they were being overprescribed?
Make money.
Kind of. Patient satisfaction.
Mm-hmm.
How many of you, when you go to the doctor and you leave the doctor's office, if he or she doesn't write you a prescription, you don't feel as if you've been satisfied? So back in the late 90s, the hospitals started doing these surveys and asking for patient satisfaction. And patients weren't satisfied unless they went home with medication. And medications that they typically liked were Schedule 2s. So your Vicodins, OxyContin was in the process of being developed. But it was those drugs, those opiates that everybody wanted. Now, did they use them? No, not all the time. It wasn't necessarily a big problem, but they had stores or stashes of them. The big problem where they talk about where it originated was actually like West Virginia, bless you, blue collar towns, because individuals that would get hurt, in order for them to be able to still make a living and put food on the table, they had to work. So they would take the medication that they had, and then they would turn to Aunt Sue or Cousin Bob and say, hey, listen, do you have any of your medications left over? And that's how it got passed around. When you're not using a drug for what it was prescribed for, it's called diverting. You may hear the word diversion. And it got worse and worse and worse. And then it was 2010, 2011 where it became really, really bad, because the DEA started going after manufacturers and distributors and physicians and the like. And they started targeting them with excessive fines. So this turned into an epidemic. Now, I want to make sure that I put this out there and we talk about the problems, whether it's the manufacturers, such as Purdue, the distributors, such as Cardinal Health, the prescribers, the physicians, the pharmacists who fill it, or the patients. Where does it actually lie? Do you know I'm going to ask, do you know who's responsible for determining the number of Schedule 2s that are manufactured every year? Can I, as Purdue Pharma, manufacture as much drugs as I want? DEA. They will set the number. Now the problem is DEA is not funded. So DEA funds themselves by what they take. So they're the ones that are saying that, hey, listen, it's a problem with the manufacturers, it's a problem with the distributors because they're diverting the drugs. But in essence, the reason that there's been an increase in the number of drugs that are produced is because they raise the limit, because they get money for that. So the government is just as much to blame as the manufacturers, distributors, and prescribers.
Okay, when you say they raise the limit and then they get money from that, who's paying?
The manufacturers. So I want to make sure that you understand that it's a vicious cycle here, that everybody is involved. We always think that it's Big Pharma, and we always want to blame Big Pharma, but it's not just Big Pharma. Big Pharma can't produce unlimited amounts of oxycontin. They have to have an approval for that. So if they're only allowing for X amount to be manufactured, then that's all they can. That's all they can manufacture. So there can be shortages because once it's manufactured, then it's on the prescribers. How much are you prescribing? Well, if everybody wants hydrocodone or oxy, and they're saying that's fine because I don't want to be the one that they say they get a bad Yelp review, then they prescribe for it. And when you run out, and you go to another drug. I don't have it listed on here, and I don't know, I just realized it, I don't know why, but I missed tramadol. Tramadol is probably the most prescribed drug now because it is no longer, it's not a Schedule 2, it's a Schedule 4, and it has less addictive properties and less euphoric properties. So I'll try and touch on it if we have time a little bit.
You said it's a Schedule 2?
No, it's not. Tramadol is not. That's why. It's highly prescribed. All right. So why do we need these drugs? If you've ever been in pain, can you function? And when you talk about a broken arm, when you talk about a tooth extraction, that pain is short-lived. So can you survive that? Maybe, you might be uncomfortable. But long-term pain, chronic pain that doesn't go away, that's something that needs to be treated, needs to be managed. So you should be able to just get rid of these drugs. Now, I will tell you that when you look at where and how these drugs are used and or abused, and I'm going to be talking about, when I say that, I'm talking about the opiates, that the majority is between the United States and Europe. 6% in developing countries is what's used because they use other mechanisms or means to manage pain. I'm not saying that you need it. I'm not saying you don't need it. I'm just saying that if you were to eliminate it completely, then the consequences that you have nothing when you truly need it for those patients. And what's the consequence of, or unintended consequence of legalizing all Schedule 1 and Schedule 2s? Death. What happens when we allow for alcohol and we no longer regulate the alcohol? No, we put an age limit on of 18, right? You have to be 21. So you see increase in abuse, you see increase in death. We've seen the same thing with cannabinoids and marijuana. Now, it's not going to kill you, but it definitely impairs you. It works by reducing your inhibition, so you get behind the wheel of a car and you might do things that you wouldn't normally do. Or you might think that you can do things that you can't. Now, typically chills people out, but it doesn't do that for everybody. So my point is that any of these drugs that are going to alter your mental status should be monitored in some capacity, because none of us are going to be free from making stupid decisions while we're on it, especially when we're either on a dissociative or a disinhibitor. Because dissociative, we'll talk about that briefly, means that it alters your perception of your external environment. So you could have lost a leg, and I give you something like a ketamine, and you think it's an itch in your back. So the brain isn't able to completely put 2 and 2 together to come up with 4. I would ask you, why is that a problem? Why, if I can't really recognize pain, or the type of pain, or the intensity of the pain, why is that a problem? Why does pain exist? Protective mechanism. So one of the things we're going to talk about is that what causes pain and the different types of pain. When you experience pain, it's to tell you to stop doing something. Pain is not meant to be. The body is not meant to experience chronic pain. Because chronic pain can ultimately kill you, because if you stop being able to feed yourself or to do the activities of daily living, then it results ultimately in death. So there are mechanisms that when you experience pain, especially intense pain, then the body checks that pain. The ascending pathway brings the pain up to the brain, right, through the thalamus and to the various regions to say, hey, listen, this is where it hurts and this is the intensity of it. And then you have the descending pathway which modulates it. So once it goes up and you go, oh my God, that hurts, then you're able to manage that pain. So you're aware of it, but it's not crippling. It doesn't mean that you can't walk away from a situation. It doesn't mean that you can't stop doing something. It makes you aware that, hey, this is a problem. You've got an issue. Please take care of that issue. But it doesn't want it doesn't want that pain to be so intense for so long that it results in you not being able to function. And that's what the descending pathway does. And it does it through GABA. It does it through, what other things? What other mechanisms do you think we modulate? I think it was in the video.
Descending pathway allows.
The substance P.
Decreasing substance P.
No, I was asking.
That's okay. Go ahead.
Descending pathway allows chronic pain.
Allows for modulation of the pain. So the gating takes place. When you hear people talk about gates and modulating the pain, that means that you have a descending pathway that's modulating it. Otherwise, whatever stimulus you have that initially comes in, that sends it up to the ascending pathway, it's pure. There it is. It's unadulterated. I slam a hammer on my hand, and the number of nociceptors that I activate correlates to the intensity of the pain. And then it goes away. Or I should say, the intensity of the pain is decreased. Well, that's the descending pathway saying, okay, listen, you messed up your hand. Go get it fixed. It's not gonna let you forget about it right away, but it's not so terrible that you can't think. That's the descending pathway. So that's where GABA comes in, that's where encapsulins come in, that's where serotonin and norepinephrine come in, because they can decrease the amount of neurotransmitter that's being released from the presynaptic terminal inside of the spinal cord. You can increase the encapsulins or the opioid receptors, and they will decrease the amount that's being released, and they can also affect the postsynaptic terminal, and they can modulate the intensity of the transmission going in the ascending pathway. So we have this ability to modulate pain. So that becomes very important because these are all targets. So I just named 3 targets for pain, right? Encapsulins, your opiate receptors. I named GABA because if I increase the amount of inhibitory neurotransmission, and I mentioned serotonin, norepinephrine, because they can work presynaptically on that, what they refer to as that primary neuron, and alter the amount of neurotransmitter that is being released that correlates to where the pain came from. So it comes from the periphery, comes in. I can decrease the amount of neurotransmitter.
What was the first one? What was the first part you said? You said GABA.
GABA, the opioid receptors, and then serotonin, norepinephrine.
What's the other name you keep saying for opioid receptors?
Encapsulins. Encapsulins. It's an endogenous. We'll say the endogenous opiates. Encapsulins. ENKA.
E-N-K-A.
PHLIN. I think it's a PH.
E-N-K-A.
Yeah, encapsulin.
So the serotonin, norepinephrine, that's affecting your first order neuron, like before the synapsing to take place?
Right.
Okay.
So that means the second order neuron has less intense transmission. And you can modulate the thalamus. And the thalamus is where perception comes in. So that's where your ketamine and a number of other drugs come in, where instead of it sending it to the arm, it sends it to the leg, or it sends it from the face to the back. And the body now starts to, it's a dissociative, so it's not sure how to process it, because there's numbers of checks and balances. But the thalamus is that ultimate regulator, and as it sends it in the wrong direction, the body doesn't really recognize the intensity of the pain, because it's now confused. So that's how those drugs work. So I covered a lot in that on what I'm gonna cover in these coming slides. So that was a big forecast. So it kind of helps you understand as I put these up. So as we talk about what pain is, unpleasant sensory and emotional experience associated with or the actual potential tissue damage. It can be physical pain, the peripheral pain, and we'll talk about that, central type of pain, somatic versus neuropathic, and then psychogenic. We talk about thresholds all the time, right? For various things, to initiate an activity, to cause, for a stimulus. I have so much of a threshold before I lose my temper, right? Threshold's a common marker. Does everybody understand when I talk about threshold what I mean? That you have to reach a certain threshold before you trigger a heartbeat. I have to reach a certain threshold before I lose it. All of my kids. I never lose my kids. So if I was to break up with my significant other, do I truly have heartache? Has anyone not gone through a breakup or a loss?
Oh, I lost it.
You want breakup? Oh. So do you not feel terrible? Are you not hypersensitive to certain things? So I would tell you that the psychogenic pain is real. That what it does is that it primes you for hypersensitivity, where something that didn't hurt now hurts or hurts more. So don't think that it doesn't exist.
So, question. In clinicals, in the ICU, there was a patient, an older lady, and her son had died from being shot. And they kept saying she is, oh my god, I don't know what they called it, something with heartbreak. And like there was,
Broken heart syndrome.
yes, broken heart syndrome, that's exactly what they called it. And I was like, is that real? Like, or is, like there was nothing really wrong with her, but she was like out of it.
Do you know what the primary neurotransmitters are that are out of whack when you start talking about depression? Serotonin, norepinephrine, dopamine. I need two of them that are modulators in pain. So as I experience this psychological change, I change the balance and the concentration of serotonin and norepinephrine. And if it's in the wrong concentration, or it's in the wrong place, then it can absolutely hypersensitize me to my external environment. So can it? I would tell you yes. Okay? Because the drugs that we use and the drugs that I would say for neuropathic pain, long-term type of pain, I've had this conversation with a couple of you in the past, is that I'm not a big fan of the opiates. And you shouldn't be. What I talked about was tricyclics, and tricyclics modulate, guess what? Which neurotransmitters? Serotonin, norepinephrine, dopamine. So I want to kind of give you this picture of how this works. I know everybody watched that 8-minute video 10 times, so it's just right there. But I wanted to kind of give you that impression, or not impression, I want to give you that overview of, hey, here the pain comes in, the ascending pathway takes it up into the brain, it hits the thalamus says, look, this is where you're actually hurting. And then based on the activity within the thalamus, it says, you know what, we need to back that pain down a little bit, and it sends down through the descending pathway the ability to modulate that pain. So we don't want that hammer that hits your hand to last, that intensity to last for hours or days. We want it to last for seconds to minutes, and then the pain changes. The intensity changes. And how do we modulate that pain? Well, we modulate it with GABA, we modulate it with serotonin, epinephrine, we modulate it with the endogenous opiates. All those things will change the intensity of that pain. And because of where it's being changed, then the ascending pathway is altered. So now the signal that's being sent to the brain is less. We use this information in order to further modulate it. So sometimes we try to shut it down completely. So we just shut down an ascending pathway, and the brain doesn't even know that you've been hurt, right?
And shock, right?
I'll use this as a quick example, as a personal example. So my father-in-law has, he was a fireman that was injured at a very young age, and they put him on heavy medication for his injuries, and he never worked again. 70 years old, and he's taking the same drugs, Vicodin, Soma, and a benzo. Terrible combination. Those are the three drugs that people typically abuse. All right, when you want to look at addicts, that's how you kill yourself. You take it in the wrong dose. Now he has a very high tolerance. So he was on a little step stool, stepped off the step stool, and he fractured his foot. When I say fracture, it was a compound fracture where the bone was actually sticking out through the skin. Okay? He was, technically speaking, high as a kite. Did he abuse those drugs? Yeah. He would get a 2-week prescription, and he would take it within 5 days. So those 5 days, he didn't feel any pain. So what did he do? He tried to get up and walk. And he couldn't. The amount of damage that he incurred was tremendous. He almost died from it because he had compartmental syndrome. He was in the hospital for almost 4 months. Right? 70 years old, couldn't feel it, kept trying to walk on it. Pain, so we block it. He's not aware of the severity of the pain, and he's continuously doing more and more damage until his wife, who's in a wheelchair, rolls in he's in the closet, rolls in and says, "Hey, what happened?" Has to call 911 and so on and so forth, and then then it's history after that. But my point is that we talk about blocking it. This is a prime example of when you don't want to completely block that pain. Now he did it without being in. He was in pain, was he? If you can go a week without the medications, then there's an addiction problem, and that's not something we have time to talk about today. But I wanted to kind of put this in perspective and give you something that you can maybe relate to as you think about it. Why is it important? What are the dangers? What are the intended consequences or unintended consequences? And he hit everything. He had a benzo, so you got GABA. He had hydrocodone, which hits the opioid receptors, and then he had Soma, was actually targeting NMDA, which is another unique. It's a muscle relaxant, which is another unique mechanism. So again, put this in perspective. Who suffers from this? 1 in 5 adults, with 1 in 10 having chronic pain. Low and middle income countries, only 60% of morphine used worldwide, while they are home to 50% of all cancer patients and 9% of HIV infected. What are the different types? Somatic versus neuropathic. Somatic is going to come from, I want you to think of it as a periphery, all right? So I'm going to use that hammer again, and I hit my hand. What is the trigger? Does anybody know what that trigger is? Because it did not say this in that little video. What's that initial response? What causes it? Because this is important, why I will tell you that ibuprofen is so much better than opiates for this type of pain. What triggers that pain? Inflammation. So you get all these inflammatory mediators. When we talk about inflammation, when you damage a cell membrane, what pathway do you initiate? The arachidonic pathway. So anytime you destroy a cell, anytime you have inflammation, you release all these cytokines, you break down the cell membrane. And that cell membrane is broken down into these 18 fatty carbon chains, and it is recycled. It's recycled through the arachidonic pathway. Now, under normal circumstances, this is always happening. So you don't necessarily experience any pain. When you get a sudden burst or increase in that, then it leads to pain. So it is that degranulation, it's that destruction of the cell membranes that then trigger the nociceptive receptors. And it travels into the CNS, we'll talk about that, and within the spinal cord, it's then transmitted up. All right? So bradykinin, substance P, all of those things, prostaglandins, all those things, when you hit your hand, are what the potential trigger is. So there are drugs that reduce that. Anything that blocks the arachidonic acid pathway. Steroids, COX inhibitors. So when you talk about that somatic pain, that those are the better drugs. Surgery, not opiates, ibuprofen. You can add the opiates for a little bit of help, but the ibuprofen is what's really gonna reduce that pain, because it reduces the inflammation. So general classifications, acute, cancer, and then chronic non-malignant. When the chronic non-malignant, kind of falls under the neuropathic pain, what happens when you have a break in that pathway and it's constantly being stimulated? You think of it as a short, the lights flicker. That's what happens with neuropathic pain. You have injury, damage, or a change within the communication within that pathway, so it's constantly being activated. Constantly being activated. A fib, a flutter. Okay, it's the same idea, the same concept. It's an irritation that just doesn't go away. Well, in this case, what happens is that you feel it. A fib, a little funny feeling in the chest, but when you do it to the ascending pathway, it's neuropathic pain.
Kind of like what happens with like post-amputations.
That's a little different. It depends, it can be, but now you're talking about phantom pains. That's different. Your brain has not registered the fact that it's missing. So you've been walking or doing things a certain way for, X amount of years of your life, and you want to do it again. It's just not there. It doesn't know how to process it. Okay, so we talked about that. So the creation of pain, how did it get there? Mechanisms, nociceptive, what we talked about, sense of touch and pressure, signal potential damage to body, neuropathic, caused by damage to peripheral central nervous system, or localized, shock-like or shooting pain, and then heartbreak, psychogenic pain, caused or exacerbated by psychiatric disorders despite lack of identified cause. Okay? So the pathway, how does this work? We've talked about this in generalities, then we're going to kind of put a couple pictures and some words to this. So transduction is the actual noxious stimulus. Transmission is the electrical events that are transmitted along neuronal pathways. Modulation is just that. Modulation occurs at the level of whether nociceptive pathways, dorsal horn, or within the thalamus and higher brain functions, and in perception. So your subjective experience to pain. As we talk to transduction, we have an injury out in the periphery, and it can be serotonin, bradykinin, histamine, prostaglandin, substance P, that all are part of that initial activation. Transmitted into the dorsal horn, where there's two primary neurotransmitters. What I was disappointed in was that and I can never find a good, clean video that I think does a good job of talking about everything, right? Because then it would be 8 minutes. And I went through several, osmosis, Lecturio, trying to find something that kind of gave you that overall picture without missing as many things as possible. But who do you think the primary neurotransmitters are within the dorsal horn at this primary neuron that's communicating that information up the ascending pathway? Who's the primary excitatory neurotransmitter? Last session.
Prostaglandin? Is it prostaglandin?
Prostaglandins are going to be out in the periphery for the sensitization. Can you have prostaglandins in there? Yeah, you can. That's not the primary neurotransmitter. Glutamate. Now the video actually talks about substance P, and substance P is a player. But again, the primary excitatory neurotransmitter is glutamate. And I would tell you that with excessive activation of the excitatory pathway, then you not only get activation of the glutamate receptors, you then get activation of the, you know what the other receptors are? NMDA. I'm not going to talk much about NMDA, but I want you to hear this. The way NMDA works is that when you get excessive stimulation of the glutamate receptor, you have this ascending pathway, and the pain is meant to be really bad. but the descending pathway is trying to modulate it. How do you overcome that? That constant activation of the glutamate, and you need a couple other factors in there. What it does is it now activates a secondary receptor, the NMDA receptor. And the NMDA receptor is a mega.
This is bad, real bad.
And that's what NMDA does, is that it accentuates that excitatory signal. So current drugs, future drugs will target NMDA to block the accentuation of that signal, hence the soma that I talked about.
All the two neurotransmitters, glutamate and
Subsequently, as the excitatory within that dorsal horn. Okay. And then as you come down, I'm going to take that out. I was playing with that. Sorry. That second picture. As you talk about inhibiting the ascending pain, these are the drugs that typically will do that. NSAIDs, lidocaine, capsaicin, opiates, cannabinoids, and ketamine, because it can modulate either the periphery or within the dorsal horn. And then we talk about the descending pathway, GABA, tricyclics, cannabinoids. You can also, I like to put opiates on both, maybe not, because it really is modulating the upper. It's activated without the ascending pathway. I wanted to kind of give you an overview of how and where this works. Dorsal horn, periphery, nociception, thalamus, and then you can modulate it anywhere within that spinal cord. Okay. All right, drugs. So when we talk about peripheral management, the ascending pathway, we're going to talk about the NSAIDs, acetaminophen, lidocaine, and capsaicin. This should talk to the general concept. So there are other drugs? Absolutely. You want me to give you a list of those drugs to memorize them all? Absolutely not. But as you hear them, and you hear the mechanism of action, and you should know how and why and where they work. That's the key. I put up a list of just some of the NSAIDs, and these may be some that you encounter. The ones that I'm going to hold you accountable for are ibuprofen, naproxen, diclofenac, meloxicam, and celecoxib. Those are the ones that I want you to be aware of. And we're going to talk about why in a minute. Where do they work? Where do most of these drugs primarily work? Some of them have other caveats to them, but they primarily work to block what? I know you've heard this. COX pathway. So a general description of what this looks like is that anytime you have cell damage, when that cell ruptures, you have to reconstitute a new cell. It's using the lipid bilayer. It's going to be broken down and reused, right? It's kind of like recycling. Well, if it's within normal constraints, normal concentrations, nothing happens. If it's in high concentrations, it's a result of additional damage, and you've got other inflammatory mediators there, then that arachidonic acid pathway induces additional COX-2 enzyme, which then produces high levels of prostaglandins and ultimately leads to pain, heat, swelling. That's the COX-2 pathway. Is that arachidonic acid? What I didn't show you was that, what's the other half of it? And it's not, this is just showing that there's a COX-1 and a COX-2. This is constitutive, and this is why when we talk about some of these drugs, why we get the side effects, the platelet regulation, kidney function, regulation of stomach acid, this is all COX-1. COX-1 is always there. When you have pain and you increase the amount of arachidonic acid, then you have a quick upregulation of COX-2. And that allows for COX-2 to produce these other products. But when I block the COX pathway, because it's two pathways, so arachidonic acid goes two ways. Cyclooxygenase and lipoxygenase. You heard that? No? So lipoxygenase pathway is the one that is responsible for bronchospasm, constriction, and additional inflammatory mediators. So it's gonna call additional inflammatory mediators to the site of the injury. The COX pathway is what lets you know that there's a problem. So I got fever, I've got pain, I've got swelling, that's COX. But I want to make sure that I keep the signal going as long as I have an increase in arachidonic acid. So I need somebody to recruit. My recruiter is the lipooxygenase pathway. Make sense?
So the drugs work to block COX or they work to reduce arachidonic acid?
They block COX.
COX-2 or
Steroids.
COX-1?
So we'll talk about that. Some of them are COX-2, some of them are COX-1 and COX-2. Steroids block the arachidonic acid pathway. So steroids work much higher up, why they're much more powerful, and they've got greater side effects.
What drugs block COX-2?
NSAIDs.
NSAIDs? Okay.
They also block COX-1, right?
Can be. Some of them are selective, others are non-selective, so let's talk about that. This talks about what prostaglandins do, and we've kind of talked about that, how they contribute to the fever and pain, and what happens as you activate the pathway where these drugs work. So what I did was I put this little thing up here. It's in your handouts. So you see arachidonic acid and lipooxygenase pathway, arachidonic acid, cyclooxygenase. We'll talk about lipooxygenase pathway when we get to aspirin. But for today, it's all going to be COX. All right. Aspirin irreversibly inactivates COX-1 and COX-2, non-selective. It is irreversible, binds and does not let go. Low dose is cardioprotective. So we use it for platelet because it blocks the platelet activation. I've talked about this in the past, analgesic. So antiplatelet is 81 to about, it's actually 60 to 100, think of it like your heart rate. It never goes away, so once you block the platelets, it's not as if at higher doses it doesn't. It blocks it to the same, with the same vigor. Analgesic properties are 325 to 1,000, and anti-inflammatory is 3 to 4 grams a day. So if I'm using it for analgesic purposes, aspirin's okay. If I'm using it for anti-inflammatory purposes, it's not very good. That's why we use ibuprofen. Much more potent drug. It reversibly binds to non-selective COX-1 and COX-2, so it's going to be binding to both. So if I'm binding to both, the side effect profile, kidneys, cardiovascular, you're one with hypertension, decreased renal blood flow, those are all problems with blocking 1 and 2. What's important though is that you understand the duration, 4 to 6 hours. Because naproxen, very similar product, has a half-life of about 12 to 14 hours. Anybody that has any cardiovascular risk or has any type of renal issues should never be using naproxen. Because once you take it, it's on, it's not gonna come off. It's gonna be there for the next 12 to 14 hours. So if you start to experience any issues, it's not as if you can take it away. Where ibuprofen has a shorter half-life. Young individuals, take naproxen. Older individuals, then I'd be concerned about that, and I'd recommend the ibuprofen. If you're worried about hypertension, if you're worried about kidney disease, don't use any of these. Diclofenac.
Hypertension?
Hyper. Because it decreases blood flow, it blocks prostaglandins, so you have a reduction in the afferent arterial, which causes a release of renin. And you wind up with hypertension. Do the ibuprofen. Diclofenac. Why do I put diclofenac up there? Because it accumulates in the synovial fluid, not just after oral administration, but you can also use it topically. So it's great for arthritis. So you use it, they'll talk about a half-life of being 2 to 3 hours, when in fact it could be 8 to 12, because it gets trapped in the synovial fluid. Now here's a little catch thing for you. It works even better when you're experiencing pain, because you have a decrease in pH in the synovial fluid, which traps diclofenac in the synovial fluid. So,
Feedback loop,
sorry?
like a feedback loop.
Well, feedback in a good way, yes.
Yeah.
And I would tell you that diclofenac, you can see it used more and more, prescribed more and more for joint pain.
When you use higher doses of the drug, like a higher dose ibuprofen and like over the counter, it still has like the same half-life and stuff.
Yeah.
It just is at a higher dosage.
You go from analgesia to anti-inflammation. So anti-inflammation with ibuprofen starts at about 600 milligrams. The problem is that when you inhibit prostaglandins, right, it's going to affect not just the kidneys, potentially the cardiovascular system. And you know what the third one is that messes people up? GI, stomach. You reduce the prostaglandin, so there's nothing there to protect your stomach from stomach acid. So you wind up with ulcers.
So people with acid problem shouldn't be anything.
Tylenol. And Tylenol isn't as effective as an anti-inflammatory. Put them on steroids.
So at low doses, you run less of a risk of having the GI effects.
Yeah. Shorter half-lives. So what happens is that I tell you that when you wake up in the morning and you're really hurt, go ahead and take it. So it's got about 4 to 6 hours. Okay, so it comes off after about 4 to 6 hours. But you're not in pain anymore because you're moving. Now, you may not need it again until you go to bed. And that's fine. So that means that you gave the middle part of the day, it's gone. So everything returns back to normal. Proxin stays on. So it starts to wear off, you start to fatigue, you get ready to go to bed, now you're sore, you start to hurt again. Pop, you take it, now your body never gets a break. Your stomach never gets a break, your kidneys never get a break. That's why I don't like Proxin.
So how's that different than just popping ibuprofen every 4 hours?
Well, if you need it, you can.
Oh, okay.
And what happens is people will bleed quickly. Celecoxib, significant cardiovascular risk for stroke. Chronic use may decrease bone mineral density, particularly in older patients. Celecoxib, long half-life with fewer GI complications. Celecoxib does not have the safety factor that you might think. So diclofenac, celecoxib. Celecoxib is the primary. COX-2 selective. COX-2 selective. So it's not supposed to block COX-1, so you shouldn't have all the side effects. Guess what? At higher doses it does, and that's what happens. But it's still more selective for COX-2. Adverse effects, CNS, tinnitus, cardiovascular hypertension. I did not highlight this, but it's ulcers or bleeding is GI, and it is very common. Hematologic, they're rare, thrombocytopenia, neutropenia, even some aplastic anemia. Pulmonary is asthma. Why? And we'll talk about this in a couple of weeks, but why do you think you can have NSAID-induced asthma? Pathway, arachidonic acid, cyclooxygenase, and lipooxygenase, right? So half this class goes to cyclooxygenase pathway, the other half goes to lipooxygenase pathway. I block the cyclooxygenase pathway, so all of you go lipooxygenase pathway. And lipooxygenase does what? Lipooxygenase. It's on that little thing at the top.
We didn't get
corner.
it.
In one of the slides.
I don't think we're going
Yeah, it's not on your digital.
I'll make sure that slide really.
But it only does that if you've taken an NSAID before that, and
Oh, the NSAID will produce it.
only one, like if you only take it one time.
It'll do it every time.
It'll do it every.
Every time I take ibuprofen, I take my inhaler first.
Okay.
And if you're on low-dose aspirin, always take the low-dose aspirin first. You wake up, I have lower back pain, I want to take ibuprofen, take the aspirin first, because if not, the ibuprofen binds to the same receptors, and then when you take the aspirin, the receptors aren't there. Ibuprofen wears off, aspirin's been metabolized, you don't get the effect. They stroke. It's a tidbit. You won't see that on an exam, but I want to let you know, as you talk to your family members, take the aspirin first. Acetaminophen, mechanism of action, and it works centrally through COX-2. They talk about a splice variant being COX-3 for the most part. What they've all agreed on is that it works centrally at COX-2. What I want you to know is it has little to no anti-inflammatory. It does work for pain and fever, because that is central. What I want you to walk away from is that you know that you should never combine this with alcohol. Should never use more, and I'll say this, it says right now it's at 4 grams, but I'm telling you it should be at 2 grams. You should never use more than 2 grams of acetaminophen a day. You shouldn't. The reason is that it uses, and I have it in the notes section, it uses 2 different pathways to be metabolized. So when the sulfonation pathway is overwhelmed because of the amount of acetaminophen you have, and it moves through a separate pathway, and that pathway will destroy the liver. Consumes glutathione, cysteine, and because of that, then the body can't protect itself. Bless you. So you wind up with additional free radicals, destroys the liver. So what product or what drug will reinstate the cysteine, will help elevate or increase the glutathione? It's neutralized with, it's N-acetylcysteine. Sorry, I'm missing the N. N-acetylcysteine, otherwise known as Mucomyst.
Those last two aren't on our slides either.
These two?
Yeah, they are.
All right, I'll slide these back over because I'm going to highlight them red. This is very important.
They're online.
So what was the other word for N-acetylcysteine?
Mucomyst. I'll put it in parentheses. Lidocaine. What I want you to know about lidocaine is that it blocks sodium channels. The reason why I put it in here and mix it in here is a lot of times we're going to talk about it next week as well, is because it can actually enhance the effect of opiates. But if I block sodium channels, then I get no response. I can't, there's no pain transmission, no neurotransmission, because you need sodium channels to do it, so it completely blocks the pain from the periphery. And when do we use lidocaine?
Oh, you can use it during ACLS.
Side effects, lidocaine toxicity. I talked about the fact that you can use it during ACLS. Well, not ACLS, but that it has preferentially acts on ischemic myocardial tissue to decrease conduction, so it's great for VTAC, BFib. Okay? So, I'm not sure as to where the difference is and why. But you typically use it anytime you're going to do minor procedures at the bedside. It numbs everything. So if I want to put an A-line in, if I want to cut them, lidocaine. Stitch, lidocaine. Problem is because it blocks sodium channels and it vasodilates. So it gets washed out very quickly. So when you give lidocaine, because it's a local vasodilator, it won't last very long unless you add a vasoconstrictor. So lidocaine is quite often mixed in combination with epi. So to hold it in that location, not very long, but long enough for you to sew them up, cut them up, whatever you need to do. 15 minutes, 20 minutes, and it's gone. Okay?
Is it epi?
Yes, epi. So epi is used in combination with lidocaine. We are not going to get to opiates.
Yes, gotta be more possessive.
So, let me get through capsation, I'll tell you what we're gonna do. All right, capsation. Anybody familiar with capsation? Pepper spray. Anybody ever been sprayed with pepper spray? You have never been sprayed? I can't imagine.
I was just about to
Wait.
say, Brady would be the only one, or you.
All right, so this is, and I'm gonna take a breath so I can kind of tie what we talked about together, because I know we're not gonna get to the next section. What you'll learn about me very quickly is that if we use anything or do anything, I will always test it on myself first. So I have, and I know you've heard this, and I've allowed students in the past, I won't do it today because it's just too painful, to do sticks on me or A-lines in a controlled environment. And I will tell you that I've sprayed myself with pepper spray, and it hurts. Because it induces release of substance P. So it's terribly painful. That's an acute situation. So why in God's name would we ever do this for pain management?
To distract?
Desensitize. So if I do it in a low enough concentration as a topical agent, and I'm constantly rubbing it on that particular area, that in about 5 to 7 days, that I desensitize and deplete substance P.
Kind of like Tiger Balm?
No.
Is it a similar idea?
Tiger Balm uses, I think it's methyl. It uses a different combination. I'd have to see exactly what's in it, but I don't think it has capsaicin.
Okay.
So by depleting the substance P, that it absorbs exceptionally well into the CNS. So I can reduce the amount of substance P that is then released as a result of the pain, acute and or chronic. And chronic pain can be your arthritis. So I can use it in very specific areas in order to reduce the pain. Because now I just don't have the neurotransmitter anymore. It's been depleted and or the receptor has been desensitized. It's not an acute treatment, it's a chronic treatment. Okay?
I thought you said it's chronic and acute.
Well, so you have to use it chronically to manage acute pain.
Okay.
Does that make sense? It takes time to deplete and desensitize the receptor or the neurotransmitter, and then when you do experience the acute pain and chronic pain, it's not as intense. Doesn't mean it goes away, because it's only one factor. As it was pointed out, substance P is one of many that will activate the nociceptors, and then when you get central, it's substance P plus glutamate. All right, so opiates. I guess I'll be busy today. Tomorrow, I'll do no more than 10 minutes to give you the highlights for opiates. The important thing is going to be not just the drugs themselves. You should have an understanding of where they work. Okay, I'll highlight the drugs that are unique. Methadone is unique because methadone has a very slow onset, so you don't get the high with methadone. It's often used to wean people off. And then buprenorphine, because buprenorphine is a mixed agonist. Those are two drugs that you're going to hear me point out. The rest of them are going to be similar, and all we're going to do is talk about the potency of those drugs. When it comes to withdrawals, what are the 3 classes of drugs that will kill you with withdrawals? Alcohol, benzos, barbiturates. So does withdrawal from opiates typically kill you?
No.
But you are freaking miserable. Miserable. So talk about what those withdrawals look like. The other thing too is tolerance. So I want you to understand what tolerance is, and I want you to understand what tolerance is in respect to opiates. Because when somebody presents, what are those things that go away, and what are those things that don't? Okay? emergency room, you could be your friends, your family. If somebody comes in and you're trying to treat or manage, and you say, so have you taken anything? No, I haven't taken anything. And I can tell you that if you're taking meth, if you're taking opiates, there's a handful of drugs that if you're taking them, all I need to do is, 30 seconds with you, and I'll be able to tell you what's wrong. And it's because things don't develop tolerance.
So, do you know how they say that like someone ODs from heroin, so they go to rehab and their tolerance drops down, so when they come out, they take the same amount that they did right before they went in and then they OD, so is it kind of like you build a tolerance like that?
Well, yes. So they're still on it. So you build a tolerance, and there are certain components like respiratory depression. You build a tolerance to. There's a chart that I gave you.
Also, what's substance P?
Substance P, considered a neurotransmitter. I'll make sure to highlight it. Okay. All right. I know it's a lot, and I know that people are nervous, with the exams. I promise you, for this exam will be much more understanding these concepts. I spent some time on these concepts. Ascending pathway, descending pathway. So if I was to ask you about what can modulate the descending pathway, GABA, opiates, serotonin, norepinephrine. If I talk about what occurs in the periphery, it should all be about inflammation. Those nociceptors, right? Those that are driving that signal, so prostaglandins, substance P, any of the inflammatory mediators or markers. That's why when you talk about an injury, you cut yourself, you get stitches, ibuprofen works great. You should not be using opiates, and don't let your family members use opiates. Don't. Chronic pain, I still don't like opiates. I still don't like them. I like to use them as a bridge for acute. It only should be used for a couple days. After that, you should find other ways to manage the pain. The tricyclics, the gabapentins, those things that are not gonna kill you.
Okay, can I ask you a question? Why, I've been prescribed painkillers whenever, pretty strong ones, whenever I fracture my ankle. Why does it make me feel sick? I'm terrified to take them because they make
Oh,
me
sure.
feel sick.
So the vomiting center, anytime you add something that's abnormal or unusual, it's the CTZ is actually